Michael Levitt served as Secretary of Health and Human Services under President Bush. He also served as EPA Administrator, and he, of course, was also a three-term governor of the state of Utah. He joins me now to talk about what's going on with the health care debate here in Washington. And you've called, first of all, thank you for joining us. Appreciate it. Let me get your sense right now. As we sit here today in Washington, this debate taking place, how does this end? Do you think we get a deal this year, and is it a bipartisan deal?
We're still not talking about the $64 trillion question. How do you pay for it? How do you pay for it? The president has suggested we'll have $300 billion worth of reductions in Medicare costs. 2 years ago, I took a $158 billion package of reductions to the Congress. I was politically stoned by the party now in control and, frankly, by members of my own party. You need to show me the money. I don't see how they pay for this. I think adding another $1.5 trillion on top of the stimulus plan, on top of TARP, on top of all the debt we've taken on, seriously endangers the economy of the United States. I think the public's going to understand that. I think there's great concern about it. They haven't yet begun to wrestle with the big question. How much does it cost, and how do you pay for it?
All right, Mike Levitt, still weighing in on the health care debate. We appreciate your time. Thanks very much for joining us.
The cost of Medicare for All is what has killed these plans in states like California and New York, which have seriously entertained it, or in Bernie Sanders' own home state of Vermont, which actually passed a single-payer plan without talking about the cost that it was going to be. The governor who was in favor of it, when it came to be, it turned out that they were going to have to put in an 11.5% payroll tax on top of everything and a 9% increase in the state income tax. They scotched the system. In a state that has fewer than 1 million people, they decided they could not afford Medicare for all. That's an object lesson. Bernie Sanders' home state.
We will have some upfront costs, and the estimates, as Charlie has said, have been anywhere from $1 trillion to $2 trillion. But what we've said is, what my administration has said, what I've said, is that whatever it is that we do, we pay for. So it doesn't add to our deficit.
Right now, the House of Representatives is talking about a payroll tax hike, a value-added tax, an income tax surcharge. The Senate wants to tax soft drinks, beer, your employer-provided health care benefits. The president really didn't do justice to the question of how he intends to pay for his health care reform and whether or not he's going to raise taxes on the middle class.
Now, Medicare for all, if you go back to this idea that, supply and demand is not different when we're talking about medical care than it is, say, when we're talking about groceries or about the production of books or movies or clothing. When you increase the demand for something and you do not increase the supply, you are going to get limited, you're going to get waits, you're going to get waiting lists, you're going to get rationing by a bureaucrat, not by what you can do. There's no place outside of the system in order to go get stuff because it's all been public. It's all been made public.
She's 105 now, over 105, but at 100, the doctor had said to her, I can't do anything more unless you have a pacemaker. I said go for it, she said go for it, but the arrhythmia specialist said, no, it's too old. Her doctor said, I'm going to make an appointment because a picture is worth 1,000 words. And when the other arrhythmia specialist saw her joy of life and so on, he said, I'm going for it. So that was over 5 years ago. My question to you is, outside the medical criteria for prolonging life for somebody who is elderly, is there any consideration that can be given for a certain spirit, a certain joy of living, quality of life, or is it just a medical cutoff at a certain age?
Well, first of all, I want to meet your mom. And I want to find out what she's eating. Look, the first thing for all of us to understand is that we actually have some choices to make about how we want to deal with our own end-of-life care.
Kate, I'll turn to death panels in a minute, but let me ask you first about what you thought of Obama's performance this week and whether it's changed the dynamics any.
I think trying to sell this self-contradictory package is beyond even his rhetorical skills. That's the problem he's having, Al. He's telling people that the imperative for health care reform is cutting costs. But we're going to cover 40 million more people. And it's going to cost $1 trillion over the next 10 years. And his big cost-cutting measure, a sticking block for Congress, is they can't figure out how to pay for all this cost-cutting. He's also saying that the system needs fundamental reform. The status quo just is unsustainable. But if you like your health insurance and you're happy with the status quo, you can keep it. So people are spotting these contradictory parts of this bill. They are at odds with his explanation for them, and he's not making the sale.
Kate, whatever the legitimate criticisms, I mean, really, death panels, isn't that really, crazy, kooky stuff?
Well, Sarah Palin engaged in a little hyperbole, to be sure, but give her some credit. She drew attention to a part of the House bill that for the very first time Medicare is going to reimburse doctors for end-of-life, voluntary though they are, end-of-life sessions. That causes a lot of people across the spectrum concern. Why? Well, as Senator Chuck Grassley has now said in announcing the Senate's not going to have such a provision if it's up to him. Politicians should not be involved in this. Yes, it's a very important thing people consider, but not at the hands of politicians. Wait till the lobbyists get a hold of this provision. So it's legitimate to be concerned. And I think, again, the president was too flip in defending it. He said, we're being accused of pulling the plug on grandma. Well, that was too flip, because people do have genuine concerns about the government getting involved in this really sensitive area.
You may want to identify yourself.
Yes, I'm Betsy McCoy from the Hudson Institute. I'm worried about seniors and what the impact will be of a Medicare for all system on them. In countries with Medicare for all, seniors are denied treatments that seniors in the U.S. can get. The thinking is that the public health dollars are better spent on young people because the benefits will be more lasting. For example, 2 years ago, the British National Health Service decreed that seniors with wet macular degeneration could not get the drug Lucentis until they had already gone blind in one eye. Then they could get it to save the other eye. Why should seniors in the United States take that risk and support a Medicare for all system?
In Britain, there are other examples. Tarceva, the drug for lung cancer that is available here. If NICE, the National Institute for Health and Clinical Excellence, a government bureaucracy, says Tarceva is not cost effective and therefore you're too old to have it, you're denied it. You can go out and pay for it in the market, but all of your services provided then under the National Health Service are no longer available to you. Is this what we want? This is what we're talking about in Congress right now with the CER, the comparative effectiveness research. We want to do this in the United States. This is going to destroy the innovation that John Stossel was talking about, and it's going to destroy our ability to live longer and healthier lives. It's not what the American people want.
And what things they can fix right away. If you're bleeding, they'll stop the bleeding. If you need an X-ray, you're going to have to wait. That's just, and all of these costs keep going up. Nobody wants to pay any more money. And at the rate we're going, healthcare is going to bankrupt us. So not only do we have a problem, it's going to bankrupt us. And we've got to sit here and say which things we're going to do and which things we're not. Nobody wants to do that. If you show up with prostate cancer and you're 95 years old, we should say, go and enjoy, have an ice cream, lead a long life. There's no cure, and you can't do anything. If you're a young person, we should do something about it. Society's not willing to do that yet.
But what we can do is make sure that at least some of the waste that exists in the system that's not making anybody's mom better, that is loading up on additional tests or additional drugs that the evidence shows is not necessarily going to improve care, that at least we can let doctors know and your mom know that, you know what, maybe this isn't going to help. Maybe you're better off not having the surgery, but taking the painkiller.
I think
think there are a lot of structural problems with the idea of Medicare for all that are masked by the slogan. And Bob makes the excellent point that it sounds like a great principle, especially when you don't say that it costs anything. But as soon as you start to dig beneath the surface to say, what do we mean by Medicare for all? What's the role of government setting prices and constraining the quantity of care that you can get, which services, which people can get? What's the role of the private sector and competition and driving innovation? As soon as you start to pull back those layers, I think there's much less agreement among the general public. And one of the challenges is that we live in a world of scarce resources. There are budget constraints. And I think that's the same reason that people would like the answer to be our healthcare spending is high solely because of prices, and prices are just too high. If we could all get exactly the same amount of care that we're getting now and pay less, that sounds lovely. We would all live equally long and have more money for other things. But I think that that's not really feasible without having a serious conversation about restricting who gets access to what care. And Medicare for all surely involves someone deciding what list of services are folks eligible for and what list are they not. And as soon as you bring that to the surface, I think it becomes much less palatable for people.
There is a whole bunch of care that's being provided that every study, every bit of evidence that we have indicates may not be making us healthier.
But you don't know what that test is.
Well, oftentimes we do, though. There are going to be situations where there are going to be disagreements around, among experts. But oftentimes we do know what makes sense and what doesn't.
One-size-fits-all approaches don't work in medicine. What makes sense for the average patient might not make sense for you. So if a treatment doesn't work for the average patient, it might work in your circumstances, but those are the treatments that President Obama is talking about eliminating.
We're also going to have to do is start looking at Medicare reimbursements, Medicaid reimbursements, working with doctors, working with nurses to figure out how can we incentivize quality of care, a team approach to care that will help raise and elevate the profile of family care physicians and nurses, as opposed to just the specialists who are typically going to make more money if they're getting paid fee for service.
What the president is talking about is increasing access to primary care by rationing access to specialty care. Now that's fine if you're one of those patients who only needs primary care. But if you're one of those patients that needs specialty care, then your health is going to be harmed.
I want to talk real briefly about my experience with an HMO. This was in the late 80s. I was in grad school, and I was buying my first health care plan. My parents were children of the Depression, and they said, get as much health care as you can no matter what, because you never know what's going to happen. So I bought an HMO plan that cost $2,000. I was making $9,000 a year at the time. It was great. It covered everything. The first day that I was eligible, I went there, I booked an appointment, and I got about 30 tests done. And as I was walking out, I saw a machine in the hallway, and I said to the doctor, what's that do? And he's like, oh, well, it does this. Do you want it? Let's hook you up and give you a test. It was great. Everything was free. There was no price other than what I had paid already, and which would take me over a decade to pay off $2,000 that I put on a credit card check. Kids never do that, okay? It compounds. The next time, so, that's great. That's Medicare for all. The bill is paid, and then it's free. The next time I went to the HMO in order to get treatment because I had a rash or something, they were like, is it life-threatening? Is it dangerous? Do you need to go to the emergency room? No, we'll see you in 6 months, because everything was maxed out. That's what happens when you increase demand and you don't do anything about supply. That is what will happen with Medicare for all. And the problem with it is also that it won't be developing new treatments. The better thing to do is to allow markets to function much better and more clearly than they do, helping to de-link health insurance and health care from employers. That would be awesome in ways we kind of discussed. And then subsidize people who cannot afford insurance on the open market. That's the way that it works in housing. It's the way that it works in food and all sorts of other things. It'll work great in healthcare. So vote against Medicare for all and vote for a future of better care and new innovative practices. Thank you very much.
Thank you.
Canadians and Brits pay a lot for the care that they wait. The average, it's not free. Bernie Sanders will tell you single-payer health care is free. The average Canadian family last year paid $13,330 in hidden taxes for a healthcare system that rationed care and had long waits. That taxes that Americans would face under Medicare for All would undoubtedly be higher, as Nick has said, since it would cover everything under the sun: dental, vision, long-term care, drugs. The Canadian system doesn't even cover those things. Long waits, high costs, poor outcomes. This is a harsh reality for millions of people around the world who are living under versions of Medicare for All. America's largely private health insurance system does merit reform, I grant you that, but Medicare for All is not the solution. I hope you will realize this and join me in voting against the motion. Thank you.
Thank you, Sally Pipes. And that concludes round one of this Intelligence Squared U.S. debate, where our resolution is replace private insurance with Medicare for All.
323,000 Canadians leave Canada and go abroad for getting an MRI, a CT scan, or a hip replacement, or whatever, because the waiting lists are too long. Those numbers are not false. I am Canadian. I have doctors in my family. I know this. Tommy Douglas was named the greatest Canadian by the Canadian Broadcasting Corporation, the government monopoly radio and television station. So just you have to think about where that came from. So we do have long waits. I have many, many stories, but I just want people to know that when the government is fully in charge, my cousin's a doctor, my other cousin's a doctor. Doctors are paid, they're basically union members. They're paid rates set by your provincial government. Nick may be the very best cardiac surgeon. I may be the very worst. We're paid the same amount of money. There's a global budget set. So my cousin in late November, his global budget for doing cataract surgery is used up, and he can't do any more treatments unless he does them illegally, or under Dr. Brian Day's illegal Canby Clinic. So we have the Canadian healthcare system is a disaster. It's what Bernie Sanders and Pramila Jayapal want for our country, but it is going to be a disaster. My mom used to say before she died, I hope you're not becoming one of those impatient Americans. Americans are impatient. They want to see the doctor right away. They want to get their treatment right away. And we're a wealthy country, and that's one of the reasons why healthcare is expensive here.
I'm a physician. For the no team, does your argument against Medicare for All extend against Medicare for the elderly as we have it now? Are the philosophical arguments such that you would postulate, let's disband Medicare?
I think that's a valid question.
Sure. I'm happy to. I am a very late baby boomer. I'm in the second to last year of the baby boom generation, and I'm not going to collect Medicare. Medicare will be bankrupt before I'm even there. I don't think that any entitlement should be based on age. I think all entitlements or all public assistance should be based on need. Seniors currently get a ton of money from the government, both in the form of Social Security and Medicare. I think that should go to poor people regardless of age.
So, Nick, to the degree that Medicare represents a universal solution for a certain cohort, you would say no.
I think Medicare, as it is currently constituted, it covers less than 50% of its costs through various taxes and premiums and things that people pay into it. It is a big problem, particularly in an aging nation. I'm not in favor of Medicare for all. What I am in favor of is a free market healthcare system that functions like food delivery, that functions like housing, that functions like buying books and TV and clothing and things like that, where we let the market work and do its wonders, and then we subsidize and help people who are not getting enough.
You've been opposed to this idea of a public option. You call it a Trojan horse. And walk me through your opposition to this idea, because the president again yesterday defended the idea of the public option, that this is the only way to force the insurance industry to really compete.
If you're an employer and the federal government says to you, I'm going to give you the opportunity to flee this market and you won't have to deal with the vagaries or the risk, that's going to be an appealing offer. The very respected economists have indicated that as many as 120 million people would lose the option for a private plan if there was a public option. That means that those markets become inviable and the private market disappears and we don't have any more competition. I think it is a Trojan horse. It's established essentially by those who advocate Medicare for all as a means of gradually getting there. They can roll this out and say, oh, it's just competition and choice. They clothe it in the language of competition and choice, but really it's a very direct path to a government-run health care system.
Democrats, I've heard Governor Dean make this case that you'll have a public option. Perhaps Americans will try the public option, find it's restrictive, go back to the private insurance industry. There is an opportunity for a hybrid here. You still don't believe that the two can work side by side?
I don't believe it's government's role to be in that place. I think the government ought to be organizing a marketplace that's efficient, where people have adequate competition. We have adequate competition, but the market is not well organized, and I think government ought to be taking strong action to organize a market so that the private plans can compete and give people real competition. Competition from the government isn't competition. It's domination.